glowing. On peut moja tu.
Hello all. Welcome to the webinar. We're going to start in 5 minutes as we wait for the rest to join. So please be patient, just 5 minutes and then we start. Thank you. Welcome to our webinar. Today we'll be talking about patient safety and the crisis resource management in anesthesia. We have our panelists, Dr. Anesthesia Komba, Dr. Shweika Salim, and the moderator to be Dr. Papicho Ntambwe. As we proceed to start our webinar, we'd like to have some housekeeping rules. So for any questions that you have, please feel free to go to our Q&A area within the chat box and just put out your question there or your comment or anything that you feel like you need to share with the group. And then this webinar is also being recorded, and the recordings will be shared on our website as stipulated on the slide. And also, if you follow us on YouTube, our YouTube channel, Gradient Health Systems, we do have all the recordings there. We upload them there. So feel free to reach out whenever you feel like you need to go through the webinars again. And for any feedback, any questions that come up later after this session, please feel free to reach us at customers@gradienthealth.org. And now I welcome our panelists to take you through the topic and enjoy and make it interactive. As they ask questions, please feel free to raise your hand and make it a good discussion. Thank you all. Welcome.
Thank you very much, Magdalena, for that nice introduction. I'll take it up to tell what we're going to discuss during this webinar. The first point of discussion will be what is the approach to patient safety in anesthesia. The second point of discussion will be the crisis resource management in anesthesia. And the third point will be some common crises in anesthesia. There we'll discuss about hypoxia, laryngeal and bronchospasm. And the last point of discussion will be anaphylaxis. So this topic will be presented by two great anesthesiologists. The first part will be presented by Dr. Anesthesia Komba from from Tanzania. And the second part will be presented by Dr. Shweika Salim from Kenya. As it was announced during the introduction, if you have any other question that you get during the presentation, please write it in the Q&A and make it an interactive session. Dr. Letitia?
Yes.
Please, you can go ahead with your presentation.
Okay, thank you, Dr. Papicho, for the brief introduction. As I've been introduced, I'm Dr. Anesthesia Komba, anesthesiologist from Tanzania, and I'll take you through the first part, which is about the safety anesthesia. As we all know that in anesthesia, safety is our highly and highest priority. And it has been considered to be a high-risk specialty compared to other branches of medicine. Other branches of medicine being internal medicine, obs and gyn, and whatever. But anesthesia itself, it has been considered to be as a high-risk specialty. Simply because we know during conducting anesthesia, we have some drugs with their side effect, which usually occurs immediately. We have some of the techniques which we are using through provision of anesthesia, which are very risky. So if we tamper with those things, it becomes so risky to those patients, and in which it will turn to be a non-safety anesthesia. So due to those issues, anesthesia also considered to have a considerable risk of many advanced events, which leads to mortality and morbidity. And by saying so, anesthesia also is linked to be the same like the aviation industry, because if we ever been traveling through the flight, we know that no flight will take on or off before doing any preparations, before making sure that everything is set and ready to go. The same ways we need to do so in anesthesia so that to minimize any room of error occurrence. At the end of the day, we'll minimize any chance of risk of adverse events, which will reduce our morbidity and mortality due to anesthesia. Next slide, please. So from different readings and reports and some of the data from different researches, it has been documented that there is several adverse events due to anesthesia during surgery or even during non-surgical procedures, like cardiac arrest, pulmonary aspiration, drug overdose, anaphylaxis, conversion, and other so listed events. But these events, when you look them from the first one to the last one, it seems like one event can proceed to another event. For example, when you are talking the cardiac arrest, it is too broad. If we not take care of the other adverse events which have been listed below, that means there will be unsafe anesthesia and we might end up with cardiac arrest. So can you consider cardiac arrest as the least event which would like to occur simply because we have a chance of reducing other events which have been listed there before proceeding to cardiac arrest. And we have numerous causes of cardiac arrest which might occur during anesthesia, which you will see in the next slide, please. Okay, so as I've said, the cardiac arrest is just not the only separated anesthesia advent event. It is preceded by the other events before occurrence of the cardiac arrest. For example, those are the top causes of cardiac arrest during anesthesia, like drug overdose or the drugs adverse reaction, which, you know, if we are keen in pharmacology of our anesthetic agent, almost all of them, they have the adverse events and reaction. And again, as anesthetist providers, we should be so keen to avoid the drug overdose simply because drug overdose itself can cause a cardiac arrest. And how can we do that one? We should at least try to provide the anesthetic agent by quantifying them rather than qualifying them. How? We usually tend to use provide the anesthetic agents, for example, the IV drugs, by giving the patient a certain meals in spite of considering the amount of milligram in those certain meals. And giving the patient a drug in terms of meal rather than milligrams, we are keeping those patients in drug overdose. So I think that's the area we need to look upon because it's only standing alone being a risk of causing cardiac arrest. But again, there's other causes like rhythm disturbances, air obstruction, which is most likely to be the technical part rather than knowledge-wise, high and total spinal, lack of vigilance, and lack of vigilance, it can be entering on those other causes of cardiac arrest simply because if we have high spinal and you are not acting vigilance to correct those signs and symptoms of cardiac arrest of a high spine, we can end up with cardiac arrest. So lack of vigilance may cause even other causes of cardiac arrest if only you will not act on time. And why not acting on time? Maybe because you are not closely monitoring your patient. And at the end of the day, you will lack that time of noting any adverse event which will cause cardiac arrest. Likewise, to postoperative or intraoperative bleedings, also we need to be so keen in preventing them simply because we know the cause of cardiac arrest, you can group them in H's, whereby hypovolemia due to bleeding will come there. Next slide, please. Okay, so now we have seen the causes of cardiac arrest. We have seen the causes of cardiac arrest, and we know that the anesthesia itself is a risk of having the high mortality and morbidities. But due to modern anesthesia techniques and machines, we've managed to reduce the maternal the death from anesthesia from 1 death per 5,000 deaths due to anesthetic complication by the year 1970s, and to 1 death per 200,000 to 300,000 of anesthetic death complication, which led to mortality. So this reduction seemed to be, it's because of the modern anesthesia technique. And how comes? Because we have the modern anesthetic machines, we have the modern monitoring equipment, we have the safer drugs nowadays, and we have back-to-back teachings, workshops, supervision, in which we improve the anesthetic skills and knowledge. In the part of the surgery, also they have their back-to-back teachings, teaching sessions, supervision and monitoring, so that they can improve their surgical skill. Combining those things nowadays, it seems to be, at least it is improving our safety in surgery and anesthesia. And at the end of the day, it is trying to reduce the mortality during surgery so that we achieve the safe anesthesia and safe surgery. Next slide. Okay, so now we know that there is Advent Invest, yes, but how can we group them? We can group them in the 3 different groups, simply because we are the people who provide the medicine. We do some techniques to provide those medicine or anesthesia techniques to achieve our goals in anesthesia provision. But again, we have the patient factors, whereby maybe that patient has some of the comorbidities. That patient, the indication of surgery is maybe an emergency condition, or there's a difficult health that particular patient. And again, but the system factors might fail us to provide a safe anesthesia simply because there's a lack of equipment. Maybe there's a certain facility whereby there's junior anesthesia providers and senior anesthesia providers, and those senior providers, they are not providing the well supervision to those junior supervisors. So at the end of the day, we'll end up causing different adverse events in anesthesia. By saying so, we can say there's almost 4 determinants in which if they will be working together will cause a safe surgery and safe anesthesia, and the outcome of surgery will be improved, in which you will see those determinants in the next slide. Okay, so now, because we have 3 groups of things which might cause the Advent Invest in anesthesia, which were the human factors, in which we were talking about the patient, the person who provides those anesthesia technique or surgical techniques, and then we had a patient himself or herself, and then we had the system. But for those who are providing those cares, being it anesthesia care or surgical care, they need to improve their skills. In which terms? They need to improve their skills in how to perform those certain procedures. For example, in an anesthetist, in order to provide a safe anesthesia, maybe he's not well oriented or mastering a certain skill, maybe intubation or airway management, but the surgeon is very knowledgeable and skilled on performing surgery. Again, the patient is very stable, no comorbidities, and everything is there. But simply because the anesthetist is not well knowledgeable or not well skilled, there will be no safe surgery. So in order to achieve the safe surgery, in both 4 determinants, we need to put a workforce to make sure every component among those 4 determinants are well skilled, knowledgeable in terms of those who will provide those skills. And again, we need to do something to make your patient being stable. If there is any room of optimizing their patient, their conditions, we need to prepare them psychologically and getting ready and getting them ready to receive anesthesia and being operated. But again, we need to do something, maybe talking to the system, and the system is that maybe the administration, to make sure we are getting all equipment which will be used at any time when we need them. We need to talk to them so that we can have those drugs. And when I'm talking about the drugs, I mean those induction drugs, emergency drugs, they should be in place. So by doing so, if all these 4 determinants will be well kept, and then our aim of producing the good outcome of surgery will be there. At the end of the day, we'll be saying that we are providing the safe surgery and safe anesthesia. Next slide. Okay, so now, as long as we are thinking in anesthesia, we need to do a safe anesthesia. Now, how? We need to do is in those 3 phases of consideration. We need to do it preoperatively, intraoperatively, and postoperatively. And now let's start to see what will be done during the preoperative phase so as to provide the safe anesthesia and being ready to provide it. Okay, so in the preoperative phase, what should be done? If we have a list for your patients, we need to see them preoperative. And what will be done there, we need to see the patient, simply because we saw in those 4 determinant patients there. And during our preoperative phase, we will be specifically dealing with the patient and then try to mobilize any resource according to that particular patient's need. So to the patient, we will do a pre-op assessment in which, even if it is an emergency, we need to spare time, even 5 minutes, to do a quick assessment so that we can identify any potential risk if there is there. And after identifying those risk factors, you can make a proper anesthetic plan for that patient so that we know if this anesthetic technique will be good for this patient with a certain risk factor, will be good to go. And at the end of the day, we try to minimize those adverse events which we saw on the previous slides. But again, during these processes of assessing our patient through history and clinical examination and investigation, we might find something which might be addressed to some other colleagues. Maybe you need to optimize that patient. You need to discuss with your colleagues. For example, you have gone to see the patient. During preoperative assessment, you found that patient is hypertensive. And that case is an elective case. That hypertension has not been yet controlled. There's a room of optimizing that patient. How? You will need to discuss with your patient that you have this condition, and because of this condition, you cannot give anesthesia, because during anesthesia, we'll be getting a difference in hemodynamic stability. So at the end of the day, we need to see maybe other doctors or other colleagues so that they can control your patient first before going to theater, simply because, you know, if that patient who is an unstable patient preoperatively, there is a chance of getting many adverse events during the surgery, simply because of our anesthetic agent. So after addressing those concerns, any concern which was found during your preoperative assessment, you need to communicate those issues with your surgical team, so that all of you people, you'll be in the same page of managing that patient. Next slide. Okay. So after preoperative phase, now we assume everything was right. We have optimized our patient. We are good to go now. Intraoperative again, we are continuing with getting ready to that patient and the provision of anesthesia. And now what will we do? We know we need to have the certain equipment. It might be the air equipment, the anesthesia machine, the suction machine. All those things which must be needed should be prepared even before the patient entering the operating room. We are not only preparing the equipment, we should also prepare our drugs according to that patient. We should not give the same drug to all patients, even though those patients are have a different issues. We should individualize those patients. So we need to prepare those equipment and drugs according to our patient. And then talking to those drugs, preparation of drugs is not just taking a drug and putting there. We need to label them. Label it by its names, and then please label the amount of drug in a concentration, means milligram per mil, so that when you will be giving that drug, you will know that this was a certain amount of drug which has been given to this patient. And we need to have assistance, because we know we cannot do anesthesia one single person alone. There is no hero in anesthesia. So please find somebody who will assist you, whether in giving drug or giving you a certain equipment. But again, we should keep our working place be as neat as possible. Things should not be clustered or overloaded at the same place, because during an emergency, if any adverse event or any crisis will occur, we might be difficult to find something. So put it very clear, label them, make it open, easily accessible to anyone, anytime, whenever it is needed. But again, we should not remember to use our WHO surgical safety checklist. And this is used as we call it as a reminding tool. We see it in the next slide. But again, we have we've prepared our drugs, our equipment. And now we know this patient will be kept in sleep and surgery will be continued. We need again to be ready to monitor our patient. How? We have the modern anesthesia machines with their monitors and everything. So that monitoring needs to be ready before the patient is entering in the room, so that when the patient entering there, we should start monitoring even before giving the anesthetic agents. And then during the surgery, while we are monitoring, we will not be just monitoring, just see their vitals and just observing, roaming around. No, we need to monitor at the same time, interpreting those readings on those monitors. And if there is something wrong, needs to be addressed, and if it needs to be intervened, you need to do it vigilantly, fast and quick, simply because you have prepared everything in place. It will be easy for you to act is timely. And whenever necessary, please, you need to communicate with the whole team on that theater. And a certain thing which will make you communicate and a good teamwork is the only WHO checklist, simply because before even starting your anesthesia, you need to do it. And because it involves the whole team in that room, that means the chance of having the teamwork will be there. So let's see the surgical safety checklist, how it works. Okay. This is not something new. It has been there, and it is from the WHO, and it is called the WHO Surgical Safety Checklist. It is, we know it is sometimes difficult to implement this, because some people need to do things very fast, but they forget that checklist is a reminding tool. And it has been proven, it has been shown that to improve the reduction of certain risks, and also it encourages the teamwork. It has 3 parts in which it indicates that this checklist should be done even before induction of anesthesia. It will be done again before incision, before skin incision. That means before any starting surgery. And then after surgery should be done, and it has its parts and some of the question which will be asked to the team members. And looking to the top of every part among those 3, it has been indicated in the first place before induction who should be there, at least be there doing the checklist, and before skin insection it has been indicated who should be there. And after surgery, it has also been indicated. If we go through in between lines, you will find that there's a very potential questions in which, if we go through those questions, actually there's a high chance of producing the unwanted events, because there's even the questions which will be asking if even this patient is the right patient and the right procedure. Even the working equipment, there's a question they're asking if the pulse oximeter on the patient and functioning. So I assume we were there or keeping the patient there or starting anesthetic patient without even knowing that the pulse oximeter is there and working. So to avoid that, use this checklist. If you pass all these steps, the high chance you will be doing those advent events. Next slide. Okay. So if we are done with our surgery, we did our checklist, we did our surgery, we monitored your patient very well. Maybe there was a up and there advent event, we intervened them vigilantly and we communicated very well. And now we are in the postoperative phase. And we have some things here to consider in the postoperative phase so that we cannot get advent event even during the postoperative phase. And the postoperative phase starts even from theater, before even a patient going to the recovery room. If that patient, we're expecting that patient to be awake after surgery, please, we need to make sure this patient is awake and alert. Simply because maybe our plan was not this to send this patient to ICU or HDU. So that awake, which we're expecting, should be there. And again, if this patient awake, we need to make sure the air is clear so that this patient will breathe well and the circulation is stable and the temperature is stable. Simply because if anything among these is not good, anything can happen at any time. And another crucial component of postoperative care or consideration, we need also to think about pain control, in which nowadays we are promoting the multimodal analgesia. Multimodal analgesia means we need to use drugs more than one from different groups of drugs to one patient, simply because you don't want this patient to experience pain during surgery or during postoperative. So if we give this patient anti-pain intraoperatively and the patient went well, the pain was not there, we expect also to do the same after surgery, simply because you don't want this patient to be in tachycardic phase. You don't want this patient to breathe ineffectively due to pain. And you don't want this patient to be to get the long stay at the hospital due to pain. But again, before this patient going back to the ward, we need to see if that wound is bleeding or not, because don't want to be surprised to get the hemorrhage postoperatively, in which we know hemorrhage is a risk factor for cardiac arrest if that bleeding will be severe. But again, we should remember to flush all lines before discharging this patient from the RR. Remember, during anesthesia, we give this patient different kinds of drugs, and we would wish those drugs action being seen before this patient leave from our hands, simply because we might find there was a remnant of drugs in the IV lines, and when they go back to the ward, they try to, during their care, postoperative care, they are flushing their line by maybe giving the fluid to this patient, and then the patient start to present abnormally. Maybe is getting the drowsiness or stop the breath, simply because there was something or some drugs remain in their lines, and we need to flush them. So we need to flush all of them so that we don't want any anesthetic issue to happen postoperatively. Okay, so now I will end up there and we'll go to see the crisis resource management in anesthesia from Dr. Shweka.
Thank you very much, Dr. Letitia, for that wonderful presentation. It has been very clear, your presentation, and then we really got your message. Now we're gonna handle the next part of the presentation to Dr. Shweka Salim, who's gonna discuss with us about the crisis resource management in anesthesia. Dr. Shweka, the floor is yours.
Thank you very much. Good evening, everyone. As introduced, this is Dr. Shweka. I'm going to take you through crisis resource management in anesthesia. As said, It's our anesthesia is linked to aviation, hence we adopted this domain from the aviation team, calling it themselves as crew resource management. And they did their research in the 1970s that they found that a lot of accidents were caused by lethal decision making errors by individual crew members or inadequate teamwork by crews. So they came up with this domain to assist in better outcomes of their flights and for maximum safety and productivity. So crisis resource management refers to a set of principles that are dealing with cognitive and interpersonal behaviors that contribute to optimum team performance, which makes or improve human performance, which are for maximum safety, productivity, which will require understanding of individuals and a group of people with different cognitive psychological aim, and changing organizational structures, equipment designing, operational protocols, and also coming up with trainings to understand on how to run this, to manage this crisis in terms of preventing them, not they occur, and also planning them and dealing with them once they occur. So it includes most of the time non-technical skills which are required for effective teamwork in a crisis. So it's a misconception in terms of comparing it to the aviation one, because the crew resource management in aviation, they are usually using it for before flights. But we are using crisis in terms of us managing when the crisis occur. But we need to change it and use it to prevent the crisis occurring by anticipating and planning, recognizing your risk, preventing anomalies, and optimizing safety. So effective implementation of CRM during any advanced event leads to better outcomes of our patients. So in anesthesia, as we have been told, there are so many advanced events, and they are very, very, very common. Next. So once a crisis occurs, why are we talking about planning, preparing, and anticipating of a certain crisis? Because once this crisis occurs, there's potential of so many of the below things happening: panic attacks, confusion, even having errors, poor communication, poor leadership, and poor outcomes. So you need to be able to anticipate, prepare for those crises, and able to plan yourself in terms of them occurring. So the main problem we usually have in our teamwork is usually the non-technical skills, because the technical skills like intubating, inserting an IV access, or even giving the drugs, or even doing a certain technique, we've mastered that. We have knowledge on doing that. But the non-technical part is usually the problem because of leadership is poor, the communication is poor. Hence, if there's no good communication, you won't be able to understand what, or even tell each other what to do, what to be done correctly. The leadership skills are not there, so you can't delegate, you can't assign tasks. So everything with all the knowledge we have in our minds, we will not get a good outcome. So these two things, the technical skills and the non-technical skills, they need to balance for us to be able to manage our crisis for better outcomes. Next, please. Okay, so the common crises in anesthesia, we've already talked about them. There's cardiac arrest, there's hypoxia, there's high spinal, depending on what type of anesthesia you're doing, bradycardia, hypotension, bleeding. So all this, they're the ones you're usually anticipating for them in relation to you on how you've seen your patient, because your human factor is also very important. We've seen that they're also the causes of us getting advanced events in theaters or in our daily practice. So you have to be prepared because you've gone to see the patient, you've assessed your patient, what type of surgery, what kind of a patient, what comorbidity this patient has, how am I going to handle it, what am I anticipating, what am I preparing myself for because of this particular surgery and this particular patient. So all this will help to have successful outcome, and for the incidents that you've already anticipated for them because you will plan for them. For example, when we are doing a general anesthesia to a patient, you prepare for emergency drugs. Why do you prepare for emergency drugs? Because you're anticipating for it. You're not saying for sure it will be there, but you're getting yourself prepared. You're getting yourself ready. If it happens, my drugs are here. This is how it's going to be. A, B, C, D. This is how I'm going to handle it. So you need to anticipate, you need to prepare, and you need to plan. Okay? For a successful outcome, both, I'm repeating, both technicals and non-technical skills. So this model has been prepared for us to know exactly on how to follow it. Next, please. So this is the model that we have. We have, for effective implementation of crisis resource management, this is the model we are using. We're using situational awareness, team leadership, assigning tasks, decision-making, team communication. All these steps or all these parts have to be dealt with clearly. So in terms of you doing situational awareness, you have to understand you yourself, because you need to understand yourself, your personnel, your environment, and your system. So what kind of a person yourself are? What is your ability, you as the anesthesia provider? What can I do? What can't I do? What am I good at? What am I not good at? You better know yourself, your ability of what you are able to do. Do not overthink yourself. Do not have a greater attitude of you being authoritative, argumentative, or you're overthinking things that you can't do. So know your ability, know your own self. In terms of personnel, the people that are around you, what is their capability? How can they assist you? In majority of the places that we work, we don't have anesthesia provider assistance. We don't have those ones. We're not lucky enough for majority of our places. So the team you're having, build it, bring it up, teach them. This is what I need in terms of when I get a certain crisis. Let them join in terms of you giving them the knowledge. I have a hypoxic patient, or I have a cardiac arrest patient, or I have a difficult intubating patient. These are my equipment. You've already oriented your team. You know your team capabilities. You know your personnel. You have to know your system also. Your system. What is your hospital able to do? What can it do better? Or what is the limitation of the ability of your hospital? You have a patient that is critically ill, an ASA 5, for example, patient that needs to be done for surgery. But at the end of post-op care, you're considering this patient will benefit more in a close monitoring, in an ICU or a HDU. And then you look at your system, you don't have an ICU, you don't have a HDU. You communicate with your team and tell them this will be better if this patient is done for in a better institution or in a better system. So that's knowing your system, knowing your environment. Where are your things? Where have you kept your cut of difficult airway or your stuff? It doesn't have to be a cut, but you have your stuff that is separately for difficult airway. Where are you putting your cut if you're having an arrest? Where is this? So everybody is aware in your room, where are your things, and an environment is good for you. Because remember, when a crisis occurs, you have a panic attack. So you need to come and be able to know exactly where your things are for you to be able to have a better outcome in managing our patients well. Next. So that's for situational awareness. For team leadership, if you are the team leader for that particular patient, because this patient is under our care, our ability to be able to handle this patient better for a better outcome. So establish good leadership, clear leadership roles. When you're assigning tasks in the next step, you need to be the leader to assign those tasks clearly. Give those roles clearly. Give those commands clearly. request for those action, recognize for those actions clearly, so that you are able to make the better action needed. Well, for assignment, so assigning tasks. When you're assigning your task for appropriate team members, sometimes when you give, as a leader, when you're giving someone a task, they might not be able to give that task to the quality that is greater for that patient or best for that patient. You don't have to be rude in terms of giving out a direction. You give that task to somebody else who you're able to know. That is when a personnel knowledge of who is able to do what comes in, because you know your people, you know your team, you know who's able to do this, who's able to do this, and you can be able easily assign those tasks to each. Making decision, you as a leader to be able to make decision for the safetyness of the patient throughout, before the surgery, intraoperatively and post-operatively. What are you recognizing in terms of the benefits and the risk of this patient? What outweighs what? The risk outweighing the benefit outweighing the risk. So you are able to make the great decisions. These decisions can also be assisted by cognitive aids. Example of a cognitive aids is checklists are also example of cognitive aids. They give you the flow of what needs to be asked, especially the WHO's surgical safe checklist. You know exactly the questions you're supposed to ask for a good outcome. A flow chart is also a cognitive aid. And good team communication, very clear assignment of roles by team leader, get your closed loop communication, and speak up when needed to speak. Speak up loudly and clearly. Next. So the benefit of crisis resource management model, it helps to improve chances of better outcome during an advanced event, but also before the advanced event, because it helps to prepare yourself and anticipate and plan. It enhances teamwork, and it also is effective in terms of utilization of resources, the people around you, the drugs that you're having, the equipment, and also it's effective in application of soft skills, which are important in any advanced event. Next. So after knowing what crisis resource management is all about, we will do some few common advanced events in anesthesia. Not all, few, some of them. Next. So hypoxia. I'm going to read for you a scenario. A 56-year-old obese patient is undergoing a laparotomy for bowel obstruction. Preoperatively, he was reasonably fit, and his SpO2 is 95 to 96. After rapid sequence induction and intubation, the patient is ventilated and anesthesia maintained using isoflurane in air with 30% oxygen. Over the next 10 minutes, the patient's SpO2 falls from 99 to 85%. So what are the most likely causes? So let's make it interactive. So put in your chat box, in the chat box, what could be the cause of this patient's hypoxia? What are the most likely causes for hypoxia? I'm giving you 20 minutes. Magdalena, 20 seconds, sorry. Magdalena, let's count for them 20 seconds. Let's interact. Come on, type. What could be the causes of hypoxia? Next, back. Thank you. Come on. What are the likely causes of hypoxia? Intubated patient, okay. Yes, let's go. Okay. Oxygenation or ventilation problem, okay. Dislodged of ETT, okay. Obstruction in airway, leakage, faulty equipment, okay, equipment failure, okay, delayed intubation, okay. That's great. Magdalena is 20 seconds over.
Yes, yes.
Okay, so next. So when you're classifying yourself in terms of causes, always great, dislodged tube. When you're thinking in terms of what are the likely causes, always remember patient comes first. So you do your patient assessment, then you move from the patient all the way back to your equipment. So for easy memory, to remember, you remember the song of A, B, C, D, E. So A, B, C, D, E. To make it easier for you to assess everything and all through the patient, all the way to the equipment. So what's A? A is our airway. What's in our airway? Could be obstruction, could be a misplaced tube, maybe it's been dislodged to endotract, to endobronchial, okay? Accidental extubation. In terms of B, breathing, are we having a hypoventilation? Are we having a bronchospasm? Are we having a VQ mismatch? In terms of circulation, is the patient bleeding a lot, although it's low cardiac output? Are we having an embolism? Even drugs, okay? So A, B, C, D. So drugs, did we give, are we deep in anesthesia? Are we giving any drug that is respiratory depressant? Are we having a respiratory issue or an anaphylaxis? Then you go to your equipment and check your equipment, your breathing circuits failure, maybe they've disconnected or they've obstructed. Are your delivery of oxygen, like you've given 30%, maybe you can increase the 30%. Your failure to monitoring, like your equipment, your pulse oximeter has a problem, remove it, place it then again correctly. If all this A, B, C, you didn't get a problem, and the drug, there's no problem, you go to your equipment. So always remember, patient first, then equipment. So, and the next question, what action would you take in terms of managing this patient? What's your first action that should come to mind in terms of managing this patient? Next. So in terms of managing, always remember, whenever you see a pulse oximeter that is reading less than 94, you're going to assume this is hypoxia until proven otherwise. As you're looking for your cause of hypoxia, this is hypoxia, you're looking for your cause of hypoxia, you give your high flow oxygen to this patient. Like the patient scenario that we had a 30% oxygen, can increase it to 100% oxygen, clear oxygen, okay? Not mixed with air. So consider administering high flow oxygen at first. That's the first step you do. Then you can also consider hand ventilation to see. But so that when you're doing all this treatment, remember, you will be running them concurrently with your ABCDs. So you are looking for airway. Remember, when you get a problem in airway, you've gotten a tube dislodging, you've gotten a tube obstruction, you will manage it. Move again to your B. You're getting your ventilatory movement with the machine, with the ventilator is not effective. Do your hand ventilation with large tidal volumes to see if your readings will change. Then your probe. You're moving concurrently with your assessment. Probe on a patient. Is it having a good wave form or not? And if it's not, you can reposition it and then keep on checking. Reassess again. If the probe is a problem, then put it correctly. Check what's the problem with the patient. Is the problem the equipment? All this, if needed, always A, B, C, D, E. Remember, when you're having an hypoxic issue, can be patient problem, can be equipment problem. Classify them like that, and moving with your A, B, C, D, E, you will always get to where the problem is and be able to manage it. Next. So, exactly. See, patient problem, A, B, C, D, and then equipment problem comes under E. So airway, you've checked it. Is your airway open? What is your problem? Is your positioning of the tube okay? All those. So make sure you have adequately moved from A, checking everything to that particular patient that has hypoxia, whether it's an intubated or not intubated patient, and the LMA or face mask. What's your breathing? Is it adequate? Is your end-tidal carbon dioxide there? Do your auscultation. Are you getting a spasm? Are you getting a pneumothorax? Manage it as you're moving, checking your circulation. You having a pulse? Are you having a blood pressure? No pulse, we know that that's another advanced effect happening, because hypoxia will lead to a cardiac arrest, especially in children or in pediatric cases. No pulse, do a CPR and treat the cause. Drugs, which drugs? Are you having too many of those anesthetic drugs? Are you having a respiratory depressant drug? All those, and then your equipment. Okay, do you have a good oxygen supply? Is it full? Is it okay? Your breathing circuit is okay, is not obstructed or is not disconnected. Okay, next. So in another way of understanding hypoxemia, especially in one lung ventilation, a patient has less than 90 in a one lung ventilation. Always remember, when you get your pulse oximeter reading less than 94, less than 90, less than 94, administer high flow oxygen, 100%. Okay, so increase your FiO2 to 100%, and then you check, did your pulse oximeter reading change, or is it still less than 90? So if it's still less than 90, that means you're in a life-threatening situation. You need to do an assessment. What's happening? Are you having a dysfunction of the heart? Are you having a low blood pressure? Is your patient in deep anesthesia? You can stop the surgery if you're having arrhythmias, ST changes like an ischemic attack, and resume by pulmonary ventilation and assess if your pulse oximeter will change. Are you going to get a good oxygenation of that patient? Are you going to improve your oxygenation? If in terms of you increasing the oxygen to 100%, did it change your SpO2 to a greater than 90%? Continue your one lung ventilation, but remember to look for the cause and treat it, and also improve your oxygenation. And how do you improve your oxygenation? You either optimize your ventilation or you optimize your perfusion. All these flowcharts, they can be used as cognitive aids, printing them, putting them in your theaters for daily reminder and daily reading of them, for them to be able to keep on sticking and sticking in our minds and heads. Next. So the next advanced effect that we're going to go through today is laryngospasm and bronchospasm. What are the risk factors of getting a laryngospasm? Insufficient depth of anesthesia, if you're having an airway irritation of the patient, device airway you're using, hyperactivity in a patient with asthma or upper respiratory tract infection, a smoking patient, or a patient that you're sharing an airway with the surgeon. Initial treatment of laryngospasm is classically consisting of removing any triggering stimulation, ensuring you have a clear larynx, relieving any possible supraglottic component to the airway obstruction, and application of CPAP with 100% oxygen. So anytime you're suspecting a laryngospasm, because remember, laryngospasm is an upper airway obstruction. So getting an upper airway obstruction, the problem is mostly inhalation. So you get inspiratory stridors. So when you get those, put a PEEP and high flow oxygen for the laryngospasm. But if it goes to beyond being managed by this, there comes in the drugs. Next. In terms of bronchospasm, next. How do you prevent patient bronchospasm? Sometimes it's just a good history, getting a good history from your patient. Is this patient an asthmatic patient? Then you get yourself prepared that there's a possibility of me getting an attack. Is this a COPD patient? So optimize them, assess this patient and optimize. Right now, am I having a cough? Am I having a wheeze? Am I having a shortness of breath? That means this is indicating poor control. So the same decision that you need to make, remember, decision making is very important in terms of assessing your patient preoperatively, for you to be able to get good outcomes for this patient. So what medication is this patient on? Careful history of any NSAID-induced bronchospasm. Counsel this patient and encourage them, if they're smoking, to stop smoking. Patients with upper respiratory tract infections, they have higher risk of getting even laryngospasm or bronchospasm in terms of doing irritating of their airway. Pre-treatment with any inhaled or nebulized beta agonist 30 minutes prior surgery. This will be able, you'll be able to do if you have a clear history of this patient asthma attack or asthmas or COPD. Induction of anesthesia with drugs that are good, have bronchodilations, propofols, even adequate depth of anesthesia. You know, the general anesthetic drugs, the volatile, they have the bronchodilating effect. LMA has shown to also reduce the incidence of bronchospasm because it's more up by high risk of laryngospasm. If a patient is more of a regional anesthesia, it should be appropriate to be able to avoid general anesthesia which has high risk of laryngospasm and bronchospasm. So how do you manage these patients? Next. So treatment, in terms of managing the patients with suspected bronchospasm during general anesthesia, remember when you're having a patient in anesthesia, getting to peak bronchospasm is with your monitors. So you're looking at your end-tidal carbon dioxide is flaring up. You're looking at your chest movement is inadequate with the mechanical ventilation. Auscultating your patient, you're getting your wheezes, or you're getting an absence of air entry sounds. Okay, so all those will be more of monitoring yourself. You have to pick them because the patient is not awake. Remember, the patient you've already anesthetized. So once you get to suspect this is a bronchospasm, increase your oxygen flow to 100. Try ventilating by hand because you'll be able to pick the difficulties in ventilation. You can stop any stimulation because sometimes the effect of the surgery can irritate and cause vagal irritation that brings bronchospasm. Consider allergy if the patient is or anaphylaxis, and stop administration of the suspected drug or whatever you're giving, maybe a colloid or a blood product. So call for help. Always remember, when you have a problem and you're getting into a difficult or a crisis, call for help. Calling for help is part of managing. So we know that anesthesia and volatile anesthetic agents are bronchodilators. So you can deepen slightly your patient to bronchodilate through it. If ventilation through ETT is impossible, check your positioning. Is the tube blocked? Is it misplaced? Eliminate all the problem with the breathing circuit by using self-inflating bag to see if an ambu bag to see if the difficulty is either through the tubes or the patient himself or herself. In a non-intubated, consider excluding laryngospasm or aspiration, and drugs, which we'll talk about drugs next. Check your circulation, always A, B, C, D. Next, okay. So secondary management of this patient with bronchospasm, optimize mechanical ventilation, and check again what is the issue with this patient. If they require chest x-ray, if they require you aborting the surgery, and the drugs that we can use. See, the A, B, C, D comes everywhere. It's the song we anesthesia providers should be singing every day. So in terms of first-line drug therapy, salbutamol is the best drug to use, either with a metered-dose inhaler or nebulizing or intravenous. Or you use a second-line drug. These are long-acting because salbutamol is a short-acting, ipratropium. You can also use magnesium sulfate, hydrocortisone in terms of decreasing antihistamines, ketamine, and in extreme measures, epinephrine is also a bronchodilator effector. Next. So the next advanced effect that we'll talk about today is anaphylaxis. And how does anaphylaxis occur? Remember, in terms of anaphylaxis, we have different types of allergic reactions, but this is more of type 1 in anaphylaxis, which involves immunoglobulin E. and involves mast cells, basophils, and eosinophils, which are granulocytes. So the effect of that receptor, the Fc epsilon receptor 1, that is on the surface of mast cells or basophils, they already combine themselves with an immunoglobulin E onto them, not like the way the other type of immune reactions. So when an antigen comes in contact with the immunoglobulin E's, then they cause a degranulation of that granulocyte or the mast cell. In terms of degranulation, what comes out is histamines, serotonin, and all this give different reaction and different points. So bronchospasm, vasodilation that leads to hypotension, leakage leading to edemas, heart failures, and regional blood flow anomalies. All this is just an interaction of what is removed from the degranulation of the mast cells. So this is a chart that is showing treatment or management of anaphylaxis in terms of you suspecting an anaphylaxis reaction during anesthesia. So the aims of handling an anaphylaxis is correcting arterial hypoxemia. And also, because we are getting a depletion of capillary leakage and vasodilation, you need to restore intravascular fluid and also prevent the release of chemical mediators that are removed during degranulation. So you need to stop that degranulation. And all this comes to adrenaline giving. Calling for help is the first thing. Stop giving whatever you're suspecting is causing an anaphylactic reaction. The drug that you're giving will help in terms, this will be able to be prevented if we take a good history of any allergic reaction. Although sometimes the patient themselves don't know what they're allergic to because they haven't gotten in contact with that particular substance. So when you get into getting an allergic, document it that this patient got an allergic by being given this particular drug. So manage it. As I said, secondary management, you need to give drugs that will stop release of the chemical mediators, giving antihistamines, giving steroids, and bronchodilators. Next. So, in conclusion and recommendation, remember, risk of adverse events in anesthesia is super high. It's very high. Safety approaching them during anesthesia should always be a priority to prevent the adverse event. Anticipating and preparation and planning in anesthesia remains a key factor to ensuring good outcome. And during an adverse event, effective implementation of crisis resource management model can help to improve outcomes. Next question. Oh, these are our references. And thank you very much for your time and listening. Any questions?
Thank you very much to our two presenters. We're so glad for the better and wonderful presentation that you did. It's time for you to ask questions. You can just drop your questions in the box Q&A. Whilst you are writing your question, I would like to acknowledge the presence of our senior colleague from across the globe. We have Dr. Dati from Nigeria, who's also part of this webinar. Dr. Dati, are you available? Dr. Dati, can you hear me? Okay, we're having challenges to get Dr. Dati online. As soon as he's able to come to, we'll give him a minute so that he can give us his experience and what challenges he has during his practice of anesthesia and how he came along with. So meanwhile, if you have a question, if you don't want to write it down, we can give you a chance to speak. You raise your hand and then we'll unmute you so that you can talk.
Dr. Ndaba has his hand risen.
Okay, Dr. Ndaba, please unmute yourself and can go ahead.
Thank you so much, the moderator, and indeed, thank you so much to the presenters for the excellent presentation. I think we all agree that the information was quite loaded, and the presenters really took their time to go through the materials for us to be able to understand the principles. Mine is just to make a very small contribution on the use of the checklist. Generally, I think the checklist compliance and its use by us generally is very, very poor. And there was a study which was done, I think now in most facilities, as a quality improvement study, just to check on the compliance of the checklist use. And generally, the utilization is really going down. But I wanted to emphasize the importance of the checklist because, more often than not, we generally tend to have less communication between the anesthesia side as well as the surgical side over the patient. We rarely have those pre-operative team briefing before you actually start your list. But I want to remind us that, the WHO checklist gives us an opportunity to interact. If we haven't interacted earlier before we start operating in the morning, the WHO checklist gives us that opportunity to actually interact and discuss the patient, where we did not have a chance to do this prior to the commencement of surgery. So it's actually very important because it also breaks, these barriers between the teams. It also brings the teams together, enhances communication. And then should there be any adverse event, it's very easy even to work together because you've already established a good communication platform. You've already started communicating with each other, during the WHO checklist. I think it's something that we really have to make sure it's part of our routines, as it brings out the most important element, of surgical care, which is communication. So I think let's just make it a habit that regardless of whether it's an emergency, it's an elective, it's a minor procedure, we always have to make sure that we go through the WHO checklist for the more comprehensive benefit that it brings to the surgical teams. Yeah. Thank you so much, the moderator. I just thought of re-emphasizing this, as it was also, I think, mentioned during the course of the presentation. Thank you.
Thank you very much, Dr. Ndaba, for that nice contribution. Now we can allow Dr. Dati to also make some comments. Unless if there's any other participant who would like to ask a question. If there's none, Dr. Dati can go ahead. Okay. We are failing to get Dr. Dati. There's no question. If there's no question, mine would just be like to say thank you very much for participating to this nice webinar. And we hope that the lesson that we've learned today is going to be useful, and then we'll keep it into our daily practice. Unless if any other panelist has a comment to make. If there's none, I'm going to hand it over to Magdalena so that, or Ngajima, to end up the program.
Oh, thank you all for, I'll allow Ngajima, my teammate, to end the program. Thank you.
Okay, thank you so much, Magdalena. Okay, I take this opportunity to thank all participants for their time to have you until now. And also thank you so much to our presenter for the good presentation, as far as the rest of the panelists for their being part and parcel of this webinar. To Gradient, this is our normal routine, and I hope to see you on the next webinar in the next month. Thank you so much, and I wish you a good evening for those who are ending their day, and a good morning for those who are starting their day. Thank you.
Thank you so much. Bye-bye.
Bye.